Ready to go live. I believe we are live on here. Oh, there's Kat and Nicole is on a plane. We got some people on TikTok. Hey guys on TikTok. Just so you know, we are on YouTube. It's Dr. B Addiction Recovery. Hey guys on TikTok. Just so you know, we are on YouTube.
What is that?
Dr.
I'll find out. I'm not sure if it's mine.
Just so you know, we are on YouTube.
What is that?
Dr.
I'll find out. I'm not sure if it's mine. Do you have anything else open? Do you have your YouTube open or anything?
Oh, yeah.
I'll find out. I'm not sure if it's mine.
I do.
Do you have anything else open? Do you have your YouTube open or anything?
Oh, yeah.
I'll find out. I'm not sure if it's mine.
I do.
Do you have anything else open? Do you have your YouTube open or anything?
Yeah.
Oh, yeah. Okay. Do you have anything else open? Do you have your YouTube open or anything?
Yeah.
What's up, everyone? Once he gets back, we'll fix this. He had his YouTube screen open, so as soon as Dr. B closes his YouTube and gets back, we'll be ready to go. Really excited, looking forward to this. So just give us a few seconds, grace of your time with technical difficulties as we fix these, but we're committed to fixing them. So thank you for being here on time, by the way, for those of you who are. Really look forward to this one. Look forward to these every week, by the way, just so you guys know. It is, we do a lot of different things, and this is one of the things that I personally do that I look forward to because, as you all know, Dr. B is a really wonderful human being and a great resource for many people. And just to be able to come speak with him for a few minutes each and every single week is the highlight of my week, and I know it means a lot to a lot of you. So he's working through these technical stuff. What's up, Nicole? We got Dr. B's. He's gonna pop right back on again. He had a couple browsers open, I think, so there was a lot of echoes going on. So as soon as he resolves that, he'll be back in the stream. Yeah, and that link that Nicole puts on sporadically throughout the stream, feel free to utilize that link. If you click on that link, it gives you access. The link that Nicole puts on sporadically throughout the stream, feel free to utilize that link. If you click on that link, it gives you access. The link that Nicole puts on sporadically throughout the stream, feel free to utilize that link. If you click on that link, it gives you access. The link that Nicole puts on sporadically throughout the stream, feel free to utilize that link. If you click on that link, you get access. The link that Nicole puts on sporadically throughout the stream, feel free to utilize.
We're getting there.
If you click on that link, you get access. The link that Nicole puts on sporadically throughout the stream, feel free to utilize.
We're getting there. Okay.
I think it's resolved.
There we go. Okay, guys, I'm sorry about that. Parham, thanks for driving the boat while I was gone. Hey, guys, I see the guys on TikTok again. Come on over and join us on the YouTube channel, Dr. B Addiction Recovery. It's me and Parham Namatolla. As always, every Sunday, 1:45 p.m. on my channel, we start with a platform of different topics. This week is a topic that's near and dear to both of our hearts, the stigma of addiction. And just come on there, ask your questions, like and subscribe. Hey guys on I think there's Nicole. I thought she was on a plane. Okay, hey guys, how are you? Hi Parham, how are you doing?
What's up, Dr. B? In a second lifetime career, you can work on technical issues. I think you made some good progress today.
Yeah, and I was pretty quick. Well, we already have somebody on, but it says device not connected. There's an Andy on there, and it says device not connected. But while Andy gets on, so today we're gonna kind of tackle this issue of the stigma of addiction. What does that mean for you, Parham?
Oh, man. It means a lot to me, Dr. B. I think, stigma, when you think of the word stigma, there's negative connotation, there's shame, there's something that just doesn't feel that well. And for me, it's it's unfortunate that addiction gets such a bad rap, because I do believe that all of us are addicted to something that takes away the pain, you know, and addiction has a lot of overt behaviors that society sometimes doesn't like, or they judge, or they, you know, they take a lot of, they take on a lot of shame due to it, you know, but I don't see that much difference between food addiction, to be honest with you, or with excessive gambling, or with sex addiction, or with online computer addiction. A lot of the same similar consequences do occur with human beings. It does impact the brain. It does impact society. It does impact connection, socialization. It does impact health. And for whatever reason, addiction is a drug addiction. You know, alcohol and drug addiction is the one that gets the worst rap when you really look at the data and the statistics from something as so innocent as food, you know, with cardiovascular disease and diabetes and problems with cholesterol and stuff like that. More people per user probably die from something like food, yet food is okay. The drug dealer's the drive-through, and no one has a problem with that one. But when it comes to addiction, there's a lot of taboo with it. And you know, one thing is, I'm really grateful, Dr. B, to have this opportunity to talk on this topic, because if people like you and I don't help break the stigma and educate human beings on it, that means we're just relying on other people to do it at all times, man. And it's got to come from the professionals, man, because I believe it's one of those top to bottom kind of avalanches that when we change the narrative on the top, then we have an opportunity to impact more people as it works its way down. So I look forward to hearing your thoughts of this. I look forward to talking about also the stigma that's in recovery, not just addictions. I think there's a whole different stigma that's there. So yeah, feel free. I know you're really passionate about this, man. Go for it.
Yeah. Yeah, no, I agree with everything you're saying. And I think like most things, this topic needs a formal treatment and dissection in multiple fields to really get a hold of it. So I'll be brief, because this has a historical context, political context, social context, financial context, religious context, the prevailing treatment modality in the United States context. And then, sadly, all of that spills into the treatment, which makes it horrible. And it has been argued, and it is the case, that because of the social paradigm and perception on the concept of addiction, this actually reflects onto the addict, the patient. And what it does do, it actually cycles the addiction into a longer phase and recovery much more difficult. And that is my position on all of that. From a historical perspective, we know throughout different times, and it's kind of odd when even you look back into the history of the Americas, that this was not frowned upon at many points in our development as a nation. And it just came and went depending on different issues that kind of came up in social, political, and financial arenas that drove the perception. Most recently, 1920s and 30s and the 1914 Harrison Act, and you know, some guys out in California driving this financially, and then eventually the guy that was the head of the president of the DEA drove this in a very maniacal, sadistic way by putting out there a lot of false information. And racism was a big part of it against Mexican Americans and African Americans. But here we are today, and that's left for another time. What it's doing today, because it is so seeped into our institutional systems and our systemic behavior and society, and the structures that we have, family, church, friends, eventually it affects how treatment occurs, okay? And it limits the capacity of the treating clinicians to do what they should be doing. In addition, it biases them significantly. And then we end up getting responses such as, incarceration is one offshoot, right? You use it as a political thing to get voted, and then you have that disaster. We use it in the very short treatment regimens that we have, and we say, see you later, take care, and how insurance companies pay for it. It's kind of seeps into that idea of a very, very misaligned perspective by most folks on buprenorphine as a first-line treatment or medication-assisted treatment as a first-line treatment, and how it's approached by the providers and how it's approached by the patients themselves. So this issue is, I think, just as toxic and just as much of a barrier to good treatment and respect and autonomy of the substance abuse individual afflicted with this as anything else that you can think of. So, I have a lot to say, and I can get into every single one of those things. But in general, that's what this whole thing's all about. That's what the TikTok thing was all about. It was about to change minds, views, and how people approach this issue. And you know what? Yeah, by the way, what you said, you're right. If you think about it, the insanity of how we approach things. I made a TikTok some time back. What is the most addicting substance on the planet? And the answer was sugar. And so many people misunderstood that. But number one, I'm not pulling that out of my butt. That's a World Health Organization data. And the way that, people take things as a categorical ontological reality, okay? It's a construct. And the way that construct is derived, number one, sugar is addictive. Okay, how addictive is it? And the way that construct is derived is the damage it does in terms of health and the cost and burden on society and an international level. And that's how that was measured, right? So having said that, diabetes is rampant in this country, and what we used to call diabetes type 2, which is adult onset diabetes. We used to call it adult onset. It's not even applicable to call it that anymore because 11-year-olds are coming down with it, right? So all of that said, do we, the hospital floors are filled with complications secondary to poor diet. And do we stigmatize and call CPS, let's say if your kid has diabetes, or you see what I'm saying? Are they treated worse? Do we hold off insulin like we hold off pain medications? So in every way you look at it, it's a big issue. And I could go on. So I'll just start off with that.
Absolutely, man. Dr. B, what I like the most about you is how when you look at something, you don't just look at it for face value. You look at it with a multiple different angles, point of views, perspectives. You zoom out, you rotate the image, you see it for more than what appears on the surface. And I think that's how we have to start looking at addiction, because when you start talking that it's like a social, cultural, political, it's a financial, it's a medical, and you start looking at it through all those different lenses, then it becomes something that we really start to understand why there is a stigma to it in the first place, because I think that whenever there is a lot of different hands in a certain pot and there's an ability to profit from a certain thing, then the narrative becomes whatever it wants to become when we allow the power to be taken away from the professionals and the individuals going through the system. Because as you always talk about, autonomy is such an important thing, and the consumer, the patient, the advocate rights that they have is such a powerful thing that we forget sometimes that we actually do have the ability to start changing the stigma. We really, as human beings, I will not be sitting in my living room talking about the stigma of addiction if I didn't really believe in that. And I know all those things about those different laws that happened, with the crack cocaine in the 80s and how they just infiltrated into low income neighborhoods, and the sentencing for them, the sentencing laws for crack cocaine versus powder cocaine. If you go look at those, and then the incarceration of African Americans who make 13.6% of our entire U.S. population, yet house 50% of our inmates. These things are very disproportional, and it has nothing to do with a violent crime or anything like that. When you really look it down, you start to see where drugs really started to break homes and break communities and break systems and just perpetuates the problem. So the reason I'm here this afternoon with you, Dr. B, is to really allow other human beings to come on and talk about the stigma and addiction that they've experienced in their life and what they could do about it. Really what we could do about it, and be able to have a conversation, generate a conversation at least, that maybe goes beyond this live, that as people leave, they start having those conversations with other people and start realizing that we actually do have the ability to make certain changes with the way addiction is looked at, treated, discussed, talked about. And that's my vision for this. I always say maybe I'm a hopeless romantic when it comes to some of these things, and you always tell me I'm not. So
no,
yeah.
And in fact, it is happening. Number one, I never thought, but on TikTok itself, the messages we get, so many people themselves are empowered and breathe easy for the first time. But in addition to that, I have so many students or practitioners, nurses, nursing students, medical students, pharmacy students telling me they are gaining so much from this in their approach of patients. I've had private folks that aren't in healthcare. I had a beautiful letter, and I've been meaning to figure out who it's from. It's a woman, handwritten letter, New Mexico, to my medical office, and it's so wonderful. I got to find it. It's beautiful. Talking about she's not an addict. I think she's older, maybe 60, and how the channel is completely changed her view on addiction. And if I recall correctly, she was reaching out to some members in the family. So we are absolutely having an impact. And the other part of that impact, as you brought up the point of autonomy. I'm a big advocate of patient autonomy. But one of the things I try to do actively, and don't always talk about it, is this. There's a difference with autonomy than I'm going to please you, whatever you want, or enable you. And I'm going to use your world as an example of that. If you talk to some of the heavy psychoanalysts, psychologists, kind of academic guys internationally, and I've heard them have this discussion, is that therapy is not what it used to be. Because back in Freud's time or Jung's time, you'd go to these guys because you wanted to transform yourself. You knew something was wrong. You wanted someone to help you discover it, point it out to you, and give you tools. So they could say whatever. Today, the therapist's job is there to validate your bullshit, right? And say, yeah, you're right, instead of figure out, and otherwise you're going to. So in that same sense here, when I talk about autonomy, what I try and what I'm hoping we're doing here and on the TikTok and on the YouTube is, first, I want to empower with education, meaningful, honest education, whatever the topic is, so they really have the tools, they really have the understanding, and then you add the autonomy to that. And that's real critical for me. And the way I see it all.
Yeah, I think autonomy without valuable information and knowledge is almost impossible. You have to actually know what it is that you're going to be autonomous in, and the choices you're making, decisions you're making. So, man, this is great. There's a lot of action going on the side, by the way, too. Not really about the stigma too much, but there's some good stuff going on the side. So everyone, that link that Nicole keeps posting, it's a StreamYard link, and all you really have to do is click on it. And what that allows you to do is to come into our show, and there'll be a third screen that will open up. It'll be Dr. B. There we go. Caring Farm. There she is.
Yeah, we've been looking.
What's going on?
We've been waiting for her for so long. She always pops up everywhere. And she's pretty awesome. She always has something really, really insightful to tell us.
Absolutely.
I have a brand new phone, so excuse the video here, but I just wanted to say it's a great honor to talk to you, and I just appreciate everything that both of you are doing. And I think I'm a pharmacist by training, and I just think it does need to come from the medical professionals also. It's just been really sad to see the stigma that goes on, not just for addictions, but just mental health in general. And so often I think, I guess it just really touched me a lot whenever I was I had a patient come through, and I just was talking to him about his Suboxone, and he had been on it for several years. And I was just asking if he felt okay on his dose, and just acknowledged him. And he said, "You're the first pharmacist that's actually taken time to talk to me and acknowledge me, and I feel like a person." And that just it really touched me, and it's something that I want to really strive to do what I can to make things better for people. And there's a lot of stigma that I think that goes around just addictions, and any sort of thing that has to do with the brain, even. And so many of our insurance companies, they'll pay for diabetes, or they'll pay for all these different sorts of things. But I think we're starting to see progress on that front of helping to cover and treat addictions. And I'm hoping that continues. The brain's an organ just like so many other organs in the body, is how I feel about it. And I also appreciate both of you so much, just the perspectives that you have, and also how you approach people. I think a lot of it makes a lot of common, a lot of sense. So.
Right on. Well, it sounds like you are approaching people the same way. You know, we have a lot of pharmacists out there, but the caring one, because people don't care how much you know until they know how much you care. I really do believe that. I want you to know that. And that moment that you had, that interaction you had with that gentleman, caring about his medication that he's on, and just taking 2 minutes of your time to just treat someone like a human being goes a long way, breaks the stigma. And you do say a lot of valuable insight on the side chat. You are a great resource for anyone watching this. You do go through with compassion. I also agree, by the way, that psychiatrists are one of the only medical professionals that treat the organ without actually looking at it often. They just go off the symptoms, and a lot of other medical doctors actually look at what they're treating, and so symptomology becomes important. But how do you know symptomology? Is by having direct, honest conversations that you take your time, you get to know the person, you do assessments, you care. So I think the more people like us get on here and talk with each other, the more some other professionals watching this too, I promise you that, and they might just say, hey, let me try this method a little bit to see how that goes, and a few people follow that together, and all of a sudden we're changing the culture of care.
Yeah, I agree 100%, and not just on here, but I keep seeing you pop up in a lot of comments, and I want to encourage you to never stop doing the way you're approaching patients, and it's somewhat it's very, that is your truth, and it is a good truth, and I am certain you will touch lives, not only the patients, but you will change minds in your career. That's number one. You generating discussions, continue to do that, because I want people to generate discussions on our side talks and our YouTubes and our TikToks, because what I've noticed, Parham, is that there's so much education that goes on with conversations, whatever anybody, and I make sure no one's really blocked unless if they're just harassing, annoying, or lewd about things. But I try to make it so these conversations that go back and forth, people are really educated through that. So in all areas, we appreciate you. Let me ask you, what state are you in?
I'm currently in Colorado, and right now I am actually not working. I had you were an emergency medical doctor, so you would know about cecum volvulus. Have you heard of that? That's within the intestines.
Yeah. Was there a resection?
I've had multiple resections. I've had a whole bunch of intestines removed, and I just keep forming adhesions. I had a perforated appendix, so I've been really sick and unable to work here the last while. So,
what was the inciting factor the API, the perforated appendix? Was that the initial inciting factor, or was it from childhood?
They think that I just didn't have a ligament because I was born with a little tiny hernia, umbilical hernia, and they didn't know. you know, that anything had gone wrong, but it was just
That's
acute onset pain. And I've been the last resection I had, I was in the ICU and I hemorrhaged and got infection inside there. So I was in the ICU for for a while there. And
I'm so really sorry to hear that. Will you share what the trajectory is now? Is the sequelae looking good? Are you just healing and getting stronger, or is that where you're at?
too. Yeah, okay. You know, I worked in a retail setting for quite a few years, and I sure miss it a lot. But just I'm pretty. I'm thinking might have to switch, you know, from what I was doing. Right now, I'm just trying to regain my strength and my weight, and a lot of that stuff is I'm having a lot of this last one had quite a bit of small bowel, so I'm struggling some with absorption and just a variety of things. So, but I'm working through them. I'm the type that I don't want to quit, but it's an obstacle that's come up and just keep going forward. One step after another.
I think this whole community, including us, know about obstacles, working through it. Do know that we are both, and the whole we're all here for you, the whole team. Stay connected to us. Let us know if I can do anything for you at all, even if it's just support. I don't know if you've been talking to Nicole, but stay attached to us. We're going to root for you. We're going to support you. And we love your presence and your input. And thanks for finally coming on. I really mean that. You know, I'll be thinking about you.
Yeah, I just miss my career so much. So I think this gives me an opportunity to feel like I'm still trying to make a difference, because that was something every day I tried, was just to make a difference somehow, you know, touch someone's life. And it's just, I guess maybe this is a way that I can still feel like I can help some way somehow.
Well, you absolutely can. And let Parham, me, and the whole team, let us know how we, like I said, you're always welcome in here. Pop your head up and say hi to us every week. And as far as I'm concerned, we consider you part of the team, and we support your recovery 100%.
All right. Well, I appreciate everyone out there struggling with addiction and mental health, anything. Just know that you are a person and you're valuable in life.
Thank you.
Yeah, thank you so much.
Bye-bye.
Bye.
She's awesome, isn't she?
Yeah, man. You just don't know what people are going through, you know, and just I really appreciated the amount of courage and perseverance she had, and her attitude. You know, I've seen people go through, you know, different stages of illnesses, and attitude's the main difference maker. You know, how you go through adversity and how you what your outlook is like. You know, it helps that she's, you know, educated and has just a positive disposition to her. But despite of all that, she still had a positive attitude, which is something that we can all learn from here in this recovery community. It's no matter what you're going through, it's how you frame it and how you look forward, you know, instead of looking at, you know, just your immediate. So that was a learning lesson for me, to be honest with you.
Me too. In fact, she just gave me a little bit of a kick ass, because I got some challenging things, multiple challenging things. Some of them came up this week that I have to deal with, and I almost felt ashamed of my own challenges. And she was invigorating and empowering for me. So thank you, Caring Farm. And I meant everything I said. We're here for you, and don't lose touch. She was awesome, and she's so bright. The comments that she makes, I don't know how much of them you've seen, but they're just so insightful, and she knows her shit. I'm really impressed by her.
Absolutely.
Let's see, what do we got here? Let's should I scroll all the way to the top? And I'm supposed to give you control of this thing. Okay. Kat, hi, I know you're here. Nice to see you. I'm glad Nicole's back. Here's one.
So it says, President Oatmeal says, is it okay to be prescribed a small amount of Ativan for bedtime anxiety attacks while prescribed Suboxone? Is it safe? Could I die from taking the Ativan at night? So this is definitely your wheelhouse, doctor.
I'll give you a quick and short answer, President Oatmeal. If you come on, I'll give you a long, more insightful answer. And quick and short and dirty answer is it is absolutely safe. And at the same time, please discuss this with your physician to make sure it's safe. In your case, as a general rule of thumb, it is categorically safe, often misunderstood because Suboxone is a opiate. And I'm happy to give you a little more insight onto that if you come on. And thank you for the question. All right. Next. I like this. Stigma equals judgment. That's right. I agree. You agree, Parham?
Yeah, I mean, because it's whenever you don't understand something or be in denial of even trying to understand something, that means by automatically you're falling into some type of judgment, either falling into better than something or worse than something, or, some moral judgment. You see the differences. So I definitely agree with that. Yeah.
Hi, KM. Can a family medicine doctor prescribe my husband subs instead of him actually going to rehab? He is addicted to fentanyl. My short answer will be yes, he absolutely can, but nevertheless, I don't know your husband, and he might need much. I mean, if he's addicted to fentanyl, depending on his age, how long, and what other substance abuse issues there are, all the stuff Parham got into last week about childhood adverse reaction, adverse events, and I discussed. So technically, so I'll give you an example. There are many patients of different health demographics and addiction demographics that I treat simply as an outpatient throughout my office, but that's different than a family medicine guy. And I'm not putting him down because, he's doing something different. And so, I pull it off, but this is what I do. Whereas I don't know where your husband is at. And Parham, I'm sure you have a lot to say on that as well.
Well, yeah, I mean, just the part that you and your husband are talking about getting off of fentanyl. So I know that there's some stuff going on in your relationship also, so that's something that just pops in my head right off the bat because you guys have had that discussion. You want him to get off fentanyl. He probably wants to get off fentanyl. And fentanyl is not one of those drugs that people just start on. So the history becomes really important for me to find out how did the end result of fentanyl get achieved when you reverse engineer it going backwards. So was there some type of a heroin addiction? Was there a prescription pain medication? Was there, benzodiazepine addiction? And prior to that, was there alcohol? Was there marijuana? So what's the duration of use? Because the longer that duration and the more history an individual has with various substances, the harder it is to just get off of that drug and replace it with a effective pill here, Suboxone. But then all of the, like I always talk about, the psychological, the emotional, all the stuff that's been suppressed, the changes with brain chemistry that's happened over the years, the feelings of, not having what you're used to using on a regular basis, all these things come in and the rate of relapse becomes really high. It's not that easy to just stop the drug of choice, get on Suboxone without any type of supportive community or care or treatment and just move forward. Can it be done? Probably. I'm sure it's been done, but are the odds of success high in that case? Probably not. And then the other impacts that addiction has had on your family becomes important too, is to find out what those were. Were they emotional? Were they relationship? Were they financial? What were they related to? How has it impacted? Are their children involved? There's a lot of stuff that happens here. So getting off of drugs is just the prerequisite of all of the work that happens later on. So it's a journey. I hope that you aren't under the assumption that just by stopping fentanyl, your problems are going to go away. The only problems that are going to go away are problems related to fentanyl. That's about it. But everything else that's underneath it all, it's going to start to surface. And that's what recovery is a really transformational and powerful thing, but it's also a very challenging step.
This is a follow-up from SB Parham. She lives in a small town. There's no clinics out here. If that's the case, then I'm sure also the family practice doc must be quite supportive and has a broader understanding of his patients. And if that's what you have, then that is what you have. But if it's not working, you guys, I advise you really get professional help before it would be too late, or before it becomes just completely out of hand.
And there's a couple of things too with small. I'm usually a big proponent, a fan of actually people trying to get treatment in their hometown so they don't lose a lot of the support that they have. I actually believe in that. However, in small towns, sometimes there is a need to be able to find treatment elsewhere. This happens. But everything that happened this past year with the pandemic, telehealth became a viable option for a lot of people. So even though you might not be able to physically go see, the supportive care we're talking about here, I would do some internet searches to find out what type of telehealth is available around you, that you can talk to professionals, even if you can't commute to them or see them physically. There are people that are willing to and actually do provide services through telehealth. It probably wouldn't be the number one effective way, but it's sure of a heck better than not having it. So that's another suggestion I have there.
That's a great point. It just has to be in your state.
Yeah.
And I mean, we do quite a bit of that nowadays, Parham, but people got to be in the state. So yeah,
absolutely,
that's a great point. And okay, thanks, SB. Let's see. I just saw this. I see John K on different. I've seen comments before. John, that's an interesting point. If you come on and expound on that and give us your opinion, we would love that. It could generate a discussion and get people thinking, whatever your position on that is, or if you can expound on what you mean by that. Let me keep going. I see a comment about harm reduction here, which is what I'm all about. So I just kind of saw it. All right, let's see. Oh, what's this? Hey, Dr. B, I can't, but I have a question. How long does a person... I'm just wondering why, I guess they mean the buprenorphine, but the I'm thinking transdermal. So I'm just assuming they mean buprenorphine. So tubing my way home, how long as a variable being time, although the right time or the length of time is a variable, the big mistake people make is using time as to decide when to take the medication. You should use, or you shouldn't use, a clinician should use, but nowadays the people send them home. It's a clinical opiate withdrawal scale, and there's another one which is validated and just as good, but I like my clinical opiate withdrawal scale. And what that does is look at a constellation of symptoms, I think 13 of them, and it looks for a particular score. Once you are past that score, it is safe to take your buprenorphine product. So again, time is, although it takes time, time is not the variable that you can choose consistently and without being fail-proof as when you're going to take your first dose of buprenorphine, unless if you're going to wait 2 weeks, but we're talking about taking it as soon as possible. The variable, the thing that tells you for sure is withdrawal scales that are validated clinically and mathematically. Now, since everyone's on here and I got some people on TikTok, I want to point something out. As of late, and the DEA just put out a warning a couple of days ago, and in fact, they're not wrong. It's much worse than they think. Fentanyl products have a lot of different variations where they can just add a small tweak in the chemical structure. And these are really being cut into the drugs nowadays. And it appears, just anecdotally from my most recent experience the last few months, that somehow the clinical opiate withdrawal scale might not apply to these, and people go into significant withdrawal even after they reach the appropriate scale number. This is, I'm sure, either I will get a better handle on what's really going on, or the powers that be will gain an understanding of this. This is just a little caveat on the original question. Parham, do you have anything to add to that?
No, fentanyl is a problem, man. I know that, you know, me and you and a lot of people in the recovery community know it is because of what we see in the field and the sheer amount of overdose deaths that happened this last year. I mean, I can't even, if I had quantified the number for people that might not be in the field, they would think that I'm fabricating or lying, and I'm really not. It was very common this year, and you know, a lot of seizures are happening here and in different cities, and a lot of press pills are coming up, and the primary ingredient inside them is fentanyl. They're getting created in super labs, man. It's out there, and whatever information that's coming out for it, I'm glad it's bringing some awareness to it. But my hope is that it's more accurate in nature, because the problem is very, very serious.
So what I was saying, Parham, to that is that it's even worse now. Yeah, because the fentanyl is being tweaked with different kinds. In fact, carfentanil is a variation of that, which is basically an elephant tranquilizer. And in fact, since you just remind me of one more thing with this issue, is that depending on the tweaked version you get, your regular, so not only is not the withdrawal scale, and again, that's anecdotal, that's me starting to see that clinically, which means nothing until I get a feeling for it, or they look at it more rigorously. In addition to that, this I can say with confidence, be cautious. Your normal doses of Narcan are not working on some of this stuff, okay? So yeah, Parham's right. He's not exaggerating anything. This is heavy. Okay. We are in California, SB. Okay, Santa. You see anything?
Maybe the KM one. It was a 205. It says the topic is close to my heart. I'll wait till you click on it. So, it was a 2:05 p.m.
Oh wow! Okay, that's a good way to define these.
Yeah, the reason I thought this one would be a good one is because it sounds like, you know, when we talk about the stigma of addiction, this is near and dear to this individual's heart, because him or her went in for chronic pain, you know, and a lot of times people go in for chronic pain and they come out addicted to opiate medication, and which you know, when used in certain circumstances, one of the outcomes could be overdose. And unfortunately, this happened here, because I think there's a lot of lack of information education that goes in on the front end too. When an individual, I'm a high school basketball coach, Dr. B, on the side. You know, I've been coaching high school basketball for 11, 12 years. There's football players, there's wrestlers, there's athletes that get injured in high school and they get strung out on pain meds and not even knowing what is about to happen to them. And these are kids that are, you know, innocent on nature. They don't really know. The physician is just prescribing what is, you know, called for that, you know, in terms of the medical world. And before you know it, these kids, especially the ones that were like predisposed to it or came from an unhealthy environment or just had that gravitation towards drugs and alcohol a little bit, or they're using the pills for beyond their pain. It's taking away some of their emotional distress, that kind of stuff. That chronic pain, which starts off usually with an accident, I mean, oftentimes, leads to what this individual experienced in their life. So I do hope that the education component in the front end also improves as we move forward. I know you do it. You're like a unicorn, though. You know, I know you compare sometimes, and maybe you don't, but the field is not common. You know, commonly it's not like you. They don't replicate your style and approach in addiction. It's not all physicians, obviously. I'm not one of those people to put a blanket on everyone, but for the most part, they're very casual in their assessments, and they're very short in their assessments, and they don't think long-term, consequential, A to B to C to, you know, they don't play the tape forward and just treat what's in the room in that moment, thinking that it's not connected to any moment before or after it, which is odd to me.
Yeah, a lot of I think people also have underestimated, especially since all the epidemic came out, the sheer number of overdoses that were secondary to pills, prescription pills.
Yeah.
And a lot of them were legitimate, especially a few years ago. I actually, Parham, have a total of maybe 4 patients that are on straight opiates, very special circumstances. In fact, one strange circumstances is I have a guy doing like a 4-year taper because he just absolutely wouldn't get on subs. So I said, okay, I'll keep you as a patient and I'll do it. And just because I could tell. And he, in the early days, I think he was getting some either 180 or 280, not from me. I inherited him 180 or 280, 30 oxys, 30
Oh my God.
oxys. And we have him down to 52 a month, and we go down every month. But he's such a great guy, and I again, this is for me harm reduction. You don't slice the cat every way. I just knew he wasn't, really abusing, misusing. He did have initially legitimate pain, but he had a pretty good physiological dependence. And if I let him loose out there, I was worried how he was going to be managed. So, yeah, I don't give too much. But even with Suboxone, I'm really honest and try to educate as much as I can.
I know.
Let's see. You see one?
Yeah, I mean, there's another one, it's 207. It was actually talking exactly what you just said right now. It said, I think the stigma started when pain patients were being cut off or tapered with their pain medication, and they were unfortunately blaming addicts. So that's could be similar to the case you were just talking about. You know, you get you just said it was only 4 out of all your patients, so it's not the norm. But when there are individuals that are on pain medication for chronic pain, and they just cut them off, you know, and then all of a sudden the individual seeking out illicit ways of getting pain medication, and all of a sudden the label of a full-blown drug addict gets placed on them because they're seeking out, you know, pills on the black market, or they're progressing to heroin or fentanyl at that point. So that's exactly what you just talked about. You know, there was a real life example right there.
Yeah. Let's see here. There's some discussion going on about kratom, which I have quite a few videos on. You know, one of the topics while these guys are coming up with questions, we got someone online. Oli's here. Okay, let's bring Oli on.
You might want to remove that question you have highlighted too. So.
Oh yeah. How do I do it?
Hello.
Hi, Oli. Let me.
Hey, Doc. What's going
on? Good. Let me remove this, which I don't know how I can find it again.
Can you see me?
Yeah, we could see you, bud. We're just trying to remove that question real quick.
Okay.
Yeah, but we got you though.
Hey,
okay, let's go. Hi, Oli. How are you?
I'm doing okay. Well, I had a question. I got on opiates. Probably my doctor prescribed them to me because I was overweight. I was around probably 315 pounds, and I was around, I want to say 24. And no, actually I want to say 22, 23. And I was on the opiates and it helped, but I didn't like them. So I was like, hey, doc, I don't like these. Is there anything else? I tried to stop and I was getting sick and I didn't know anything about, you know, withdrawal. I was kind of like new to it. And he was like, okay, well, Suboxone. So he started me on that. And it worked really good, I would say, for probably 2 years. And I was like, it's like I'm trading one for another. So I was like, hey, is there anything else? And they was like kind of reluctant to give me anything else. I'm like, is there anything that's non-opiate or et cetera, et cetera? So I would try to stop cold turkey, and I would get so sick. I mean, just sick. I mean, I never got that sick before. Worse than the flu. I mean, I lost 60 pounds. Like, it was pretty bad. And I'm just now like getting over it. So I'm just want to know, is there any other, besides like kratom, et cetera, any other natural or home remedies or just over-the-counter meds I could take for withdrawal symptoms? Because I'm just trying to get all the, all those drugs out of my system and just, so I don't have any kind of dependence.
Yeah. Should I go ahead and start?
Yeah, I think that's perfect.
Yeah. Only how much Suboxone were you on milligrams wise?
8 milligrams.
And you stopped cold turkey. How long ago has it been?
My last script, I probably got that in my birthday around October of last year. And the last Suboxone I had, I would probably say a month and a half ago. And I'm still feeling like I'm still laying there. I've been probably in the bed and in the hospital for about probably going on 2-3 weeks, just sick. It's just a lot of nausea, throwing up. I can't keep food down.
Oh, you're still throwing up, huh?
It's the nausea and the fatigue. It's so bad. Like it just won't go away.
Yeah. Yeah. And what did your doctor say? Did he give you any advice on
I went to 2 emergency rooms because I have Advent Health, Florida Hospital. They have a new plan out, so I have them now. But the doctor I did have, I mean, if you're not paying money or if they don't take insurance, they usually don't want to see you, and they're like, I recommend somebody else. Then I'll go to someone else, and they'll see like, I don't know if it's I'm young, like I said before. I don't know if it's my race. I just don't know. But they seem reluctant to help me when I'm literally being there begging for help. Like, is there just something else you can give me besides, another drug?
Yeah.
And they just give me Zofran and send me out the door.
Yeah. So I'm going to make a comment about this. Parham, this is sort of like that upfront thing. So here's a young guy that was having arthritis pain for the most part. And it was secondary to being overweight. Now, he's a kid, right? And he goes in there and someone just hands him, what the heck does he know? He just starts talking these opiates, but actually he's really insightful and has a good personal moral compass because, he himself, he's like, what the heck is up with this? But you got to imagine, because I remember when I knew nothing about medicine or about pharmacy, it's kind of odd and scary, and you're really relying on your practitioner to be protecting you. And I can see so much negative attitudes towards us because we're just now we're just basically on the factory line of the corporate America that pushes stuff out. But when he tells me it's heart-wrenching because what happened is wherever he was before the opiates, well, he got on that opiate train and rewired his whole brain. Then he puts him on subs, which is actually the correct thing to do. But you got to have a plan, right? And then this
they pretty much stuck me on subs and expect me to just pay that, that $150 or $200 every month and just get that money. And then when you want to stop, it's like they can't help you. So
yeah. And so all of a sudden, what should have happened is, let's say we get to the subs point, he should have had a plan with this kid and say, okay, this is our long. So now here we are. Basically, it's like my buddy at USC says he gets the botched vascular surgical cases from my neck of the woods. This is the same thing. It's like, okay, it's botched up now, right? We got adhesions, we got wrong connections, bad suturing, and infections. Fix it. So that's where Oli's at, and it's like, okay, what would you do? What do you do? And I don't know enough about his case to say, all right, there's many ways to go about this, Oli, and I would have to know a lot more about you. One extreme is, hey, let's just, you jumped off the cliff and ripped the opiates off of you. It's affecting your dopamine. It's affecting all kinds of other stuff. There's going to be depression, fatigue, the vomiting. I would want you to check out to make sure it's not something else at this point. But here we are, and I would be like, if I knew everything, I'd say, let's make a decision. You've come to my office. Do we want to go this route and figure out what's the best way to get there? But I'm going to tell you, kid, it's going to take a while, right? There's no magic. And definitely don't get, please give me a call if you're about to get on Kratom. That's not the answer for you. The answer for you is nothing.
No, I've tried that. I went through that phase. Yeah.
Yeah. The answer is nothing. Really, without knowing much, it's really get your dopamine going through exercise, staying really well hydrated, eating. It's really the whole enchilada of what we're supposed to do in the first. If we're going to go this route, the whole enchilada of what we're supposed to do in the first place. Maybe get a decent doctor to. Or, maybe try a little bit of what's the sleep stuff at night, Parham?
Melatonin?
Yeah, a touch of melatonin.
Actually, I was able to sleep last night. I bought some melatonin. Okay. I'm not joking.
Good. Yeah, so I was going to tell you because I'm sure you have sleep issues, little bit of melatonin. And then here's the other thing I want to tell you. If you go down this road and plow through, every day is going to be better than the previous day, even if there's days you don't notice it. And it'll be like this. How do I show? There's an upward graph with little dips of shitty days, but understand you will get there, and you probably should have experienced that by now, but you'll get there. So that's one way. The other way is, I would say, well, let's see how crappy it is. All right, so you want 8 of subs. So why don't we start you on 2 milligrams twice a day and let me do the taper over the next couple of years? But that's, so I'm just telling you the different options that you can have. But if you're going to go this way, diet, exercise, a little bit of melatonin, touch of Zofran, make sure the nausea, vomiting is not from another cause, and every day will get better. And I'm sorry you ended up in this crappy situation. Parham, I don't know if you have some additional stuff to add on that.
Yeah, I got some stuff for you, Ollie. It's thanks for sharing all that, man. And I'm not a prescriber or anything like that, but I'm sorry to hear that you had to go through what you had to go through since the month of October, November, and here we are in April. So it's been a very challenging 4 or 5 months for you. But I will tell you this, I am a clinician, and there is something about the holistic realm of things. And you're in the Sunshine State, man. Go see if you can sit in the sun sometimes. The sun is a really, really, really valuable doctor.
I don't know if you guys are reading my mind. I'm not to cut you off, but both you guys are on point. I sit on my back porch. That helps.
No, it does.
It really helps.
Vitamin D special hydration, man, is I've heard Dr. B use the word. It's undervalued. Hydration is very important. Exercise, even if it's walking around the block, man. I'm not saying you got to go get like really, really hyped up, high intensity stuff. 30 minutes. 5 to 7 times a week, walking around the block does wonders for dopamine. It really does wonders for dopamine. Trying to get some plants, some fruit, something that is more natural in basis. So just go back to breathing. Don't underestimate breathing. That's one of mine that I got for you, man. Take some deep breaths in, fill your lungs with oxygen, hold it in, feel your lungs expand, and then blow out all the stress.
Everything you're saying,
holding on to.
Yes, you're on point, man, because I've been trying to take the holistic approach because I was just like kind of fed up with the one then another. I'm like, let me just try to.
Parham, when you said Sunshine State, you mean here?
Well, we're the Golden State. So Sunshine, I think, is Florida, isn't it?
And kind of go cold turkey. And
is that what it is? Okay.
It took a while, but I stay hydrated.
Good, man.
Yeah.
Say it again.
Oh, no, nothing. No, yeah. So just keep doing that. I was wondering how Parham knew where you were from, and I thought Sunshine is here.
Can you hear me?
It's Florida. Yeah.
You're coming in and out a little bit, but we got you.
Hello.
We can hear you. Can you hear us?
Hello.
Can you hear us?
Can you hear me? Can you hear me?
Sorry, I got. Hold on. Yeah, can you hear us?
What happened?
Hold on. Watch, I'm going to take him off and put him back on. Yeah, can you hear us now?
Can anyone hear me?
Yes.
I can,
we can hear you all.
I think it's frozen.
All right.
Yeah, we can hear. Let's see, he might pop on. Ollie, we could hear you. We heard everything you said. We're with you. You're doing the right things, and know that it's going to get better. Take those advice and keep us up. Oh, there's Ollie. Let me just get him on real quick to say bye. Can you hear us?
Hey, I got you.
Okay.
Yeah, I was just saying.
Sorry about that.
No, you're okay. I was saying, look, you're doing the right things. Our advice seems to be right in line with what you're doing. Keep us updated. Pop
Okay.
up over here every
Definitely.
week. We do want to kind of follow you and see how you're doing, and give non-medical kind of tips here on where you're going wrong. I mean, I can certainly say to you, hey, please don't get on kratom. That's the wrong thing. But keep us updated, and we're actually
Definitely.
It's thank you for sharing with us. Okay.
No problem, man. Thanks for the words, and I'll keep trying. But yeah, definitely. Thanks for the words.
Okay. Be safe.
All right, Dark. All right, Pam.
Let's get. Let me get. Bye, Ollie.
You know what my observation there was, real quick? That was pretty cool. Is when Ollie at first, when he came on, he was really frustrated with the situation. But as he realized that the suggestions that you and I were giving to him was congruent with what he was actually doing himself, you could just see he was starting to feel better, light up. He started to smile a little bit more. So he knew he's on the right path. And I think just hearing that from us really, really put his mind at ease.
Yeah, that's good. That actually, that's a good. And you're right. You're actually right. Let me bring on. Yeah, and I just saw Lorian on there. I always see her. She always has cool comments. She should come on and say hi. Let me bring on Andy here. Hi, Andy. Andy.
Hello, Dr. B. Yes, how you doing?
Hi, how are you?
I'm great, thanks. So I have a quick question, if you don't mind me asking. I was on fentanyl for like 2 years, opiates for 6 years, and then I was against the Suboxone thing. I was like, that would be the same behavior, so what would have changed? But then my doctor kind of convinced me with it. But he started me on 2 doses, 8 milligram each a day. Don't you think that this is like too much?
8 milligrams twice a day.
Yeah.
Where are you calling from, Andy?
Florida.
Oh wow, okay. So Andy, my response to that, number one, I can't respond on your particular case, but I will say this to you. Oftentimes, I run into people. A dose that I might suggest, they're like, oh my God, that's a monster dose. And that really feeds into the stigma of this medication within the addiction community and the stigma on addiction and being on Suboxone. There's a misunderstanding of dosing on this medication. So if I can put it into some sort of digestible perspective for you without answering your particular question, the average international dose is 16 to 24 milligrams where efficacy is achieved. And what you should aim for with your Suboxone dosing is 2 things. There's 2 things you need to aim for. 1, cravings. 2, withdrawal. Those are the clinical markers on your 24-hour-a-day Suboxone dosing. The theoretical ceiling is 32 milligrams, and that's not even important. A guy like me does have a few outliers where I have on 40 milligrams for different reasons. Most of my patients are on 16 to 24 milligrams. Some of my patients are on 1 milligram. So it's hard to tell. But if you're worried about in general, if 16 milligrams is an outrageous, nonsensical dose, don't worry. That is not in general as such.
Okay, yeah, that's good to hear. And about the Suboxone stigma thing, yeah, in a lot of communities, like recovery communities, like groups where I go to sometimes, even some groups they don't consider you in recovery if you take Suboxone. That really bothers me, and it puts me into this like, am I doing the right thing? Am I really clean right now? Am I in recovery? It kind of confuses me sometimes. So,
So I have a lot to say on that, but let's let more of an expert than me. This is something that irritates me to no end. I'm going to let Parham give you his feedback so you get some real professional feedback on that.
Okay.
What's up, Andy? Yeah, thank you for Dr. B for clarifying some of those medication questions. For me, man, as long as you are wanting to get recovered, whatever that means for you, whatever path that you're on to achieve that recovery is recovery. Now, the stupid stigma that some of the recovery communities have is because they feel like just because they did it some way, that everybody else needs to do it the same way is just categorically false, man. And there is actually, 12-step programs, I'm assuming is what you're talking about here. But there is also Medication-Assisted Recovery Anonymous. It's called MARA meetings. In those meetings, they're highly compassionate, highly understanding of different medications people are on, and their support. So I would check out a MARA meeting for yourself to see what kind of support you can get there for people not stigmatized. Yeah, they won't stigmatize your recovery. And man, you got to thine own self be true, You got to see, hey, why the hell do I want to get off fentanyl? Why am I trying to get off opiates? If using this, if there's a physician that's telling me, hey, there's trials all over the world that this medication's helped countless people through research get off of their drugs of choice or drugs of no choice, I like to call them, then give it a try, And it's you did say that one thing that I just want to kind of help you reframe. You said it's kind of the same thing. It's the same behavior going through it and this and that. And it really isn't, man. It's the black market where and I'm in recovery too. I'm almost 13 years clean and sober. The lifestyle that we go about getting the fentanyls of the world and getting that world is completely different than the conversation you're having with Dr. B in the moment right now, So please remove the old version of you and the drug seeking behavior with the new version of you and trying to heal and trying to recover and trying to move forward with your life. And you got to give yourself permission to do that. And there are a lot of human beings like us that understand your path is different. And the beauty of this stream that you're watching this on the side chat, there's actually a few people that have created their own recovery communities that's based without stigma and non-judgment. Connect with them, man. They're from all over. I guarantee you they got some East Coast people too. And if it's not out there in common knowledge, man, we're the ones that are going to create it. So check out a MARA meeting. Check out their literature. It's really, I think it'll speak to you in a way that you'll feel heard and understood. And really, really good stuff, man. I'm really glad that you came on and started asking these questions.
And thank you so much for the advice. Thank you so much.
Andy, if I may add to that, Real Talk Recovery, who's on there, she actually, she works with us and she's amazing. She actually, I think this is Parham. I think she runs a huge one that she started herself and grew to no end. She might be on a plane right now because she's actually coming out to visit us. But if she's not in there, Real Talk Recovery, Nicole, hook up with her. She will guide you, and she also will help you with the education of the first thing Parham picked up when you said that same thing. Hell no, it's not even close to the same thing. Both at the physiological, pharmacological, behavioral, psychological, and social paradigm, it's not the same thing. Hook up with Nicole and come over here anytime you want. We'll give you a little bit of love and support, all right?
I'll definitely do that. Thank you so much. Real Talk Recovery, Nicole, right?
Yeah, she's
I'll note that down. I'll definitely connect. I will do that.
Yeah, she's awesome, and she'll even guide you through whatever. She's so awesome. People reach out to her 24/7. I don't know how she does that, but she's cool, man. Check her out.
I will do that. Thank you so much for all your time and what you guys do for us. Thank you so much.
All right, my brother. Peace. What a neat, bye, Andy. Another neat guy, right? I mean, these guys, Parham, when we see these, and again, our original thought today, stigma of addiction. Now you're dealing with a crappy, difficult disease, and I mean, it at a very deep, fundamental way. And you have these courageous people. The disease by itself, even if you had all the support, is already difficult to overcome. And you have these guys who many might discount simply because someone who's using fentanyl, and yet they're overcoming, digesting, treating the shitty responses in such an evolved way. That's pretty damn cool, isn't it?
Absolutely, man. It's just these moments are great. I really look forward to this because that conversation in the past too with Ollie and Andy. I mean, this is not just these two gentlemen. You know, this is thousands of men and women out there that are those same people, and they're experiencing the same exact situation. So, well, you know the way groups work is when you speak to one, you speak to all, and it's really cool to be in the front lines doing this with you, man.
Yeah, no, it's in fact the honor is mine, but it's just when you think about it, it's pretty exciting. What these guys are doing and how courageous they are. Look, I keep seeing this name up here. Where'd she go? Oh, she disappeared. All right, let's.
And Sherry, I don't know who Sherry is, but I think she does a lot of cool stuff for the recovery community because on the side chat, I could see that she's very invested in it seems like the harm reduction or she's really active on our side chat. So whoever you are, Sherry, we appreciate you. I appreciate you.
Yeah, I see Sherry's very active. And I see Nicole was back or is back. I don't know. What time is it? Okay, yeah. So that was a while ago Nicole was there. Oh, okay, I see. Oh, Lorian, I always see Lorian in different places. She's kind of neat, but I'm just saying, hi, Lorian. I do see your comments, and if you want to come on and say hi. Okay.
So there, I just saw Sherry's thing at 254. She wrote what she does. She says she has a closed group for all chronic pain patients and addiction. It's called Pain Patient. So it's nobody's judge. So I knew I could just pick it up that's where she was coming from.
Okay. I'll find that. I see the Sherry thing. Yeah, this was for you also, Parham. Oh yeah. Okay. Okay.
Oh, okay. I remember that one. Yeah. You're very welcome, KM.
Okay. It's, you see anything, Parham? Hi, Misty. Yeah, I see Sherry's thing. Very cool.
There's one down there at 257.
257.
257 Chanel Paris. The timestamp is 257. Yeah. So this individual says, help. I was in a detox rehab for a week to come off oxycodone and placed on Suboxone. I am in Suboxone withdrawal and have moved, and it's Easter, and chemists, or I'm assuming like pharmacies and stuff like that, are closed or doctors are closed. So I know what you're probably going to say is see your physician, correct?
Yeah, I mean, when she says chemist, is she in the U.S.?
Yeah, I don't know.
Yeah, and I guess if she's waiting to get a script off, I mean, really the best thing without any meds, unless if she has contraindications, stay well hydrated and over the counter. I made a TikTok that NSAIDs are underrated. I'm sorry to hear that, Chanel. I mean, if you want a more detailed answer, please come on. I don't know how these things happen when they get out of detox and there's no follow-up set up, or and I don't know if Chanel was the culprit, but I'm sorry. It's kind of difficult to give you much more than that. If you want, come on and we'll do our best here. Hey, Lorian. Yeah, I always see you. Thank you for all the comments you make.
Chanel says she's in New Zealand.
Yeah, she said chemist. Oh, wow. Okay.
So yeah, New Zealand, and she's sweating profuse, so she's going through a lot of sweats.
Yeah. I don't know what access to what she has there today. I guess I don't know if today's yeah. What is the question, Chanel, of how to do that without seeing a doctor, or give me a little bit more and I'll do the best I can. Okay, I see the sweating. Oh, what I was getting to, Parham, is the idea of we were talking about this stigma, and one of the things I've noticed that I've always had a sort of an issue with, and I say this, I guess, in the kindest fashion. I've noticed that just the same, and it just might be our global culture. Uh, People that, especially the 20 somethings, at least out here in California or Southern California, when they get into recovery, that becomes a subculture and a popular culture. And this is kind of what I was thinking about when we were discussing stuff yesterday, texting back and forth. And, I find that culture, when I'm down in Costa Mesa, sitting on a coffee shop or something, I can almost tell which kids are from a treatment program. They are all kind of dressed the same. They go to the gym, which is all fine and great, especially in your 20s. But I do find it a little concerning because there's a potential for harm to that individual in that there is almost like a subculture cool crowd in recovery, and it also almost becomes, how can I capture this? It almost becomes a new addiction to be in that. Am I making sense? I'm having a little difficult time putting it on, and I'm sure you've seen it. Maybe you could help me out with this, but I find it a little concerning. It's a cultural sort of shift from the addict to the person in recovery, which should be healthy, and it usually is healthy. But sometimes I wonder about the culture that I see down here with so many treatment centers and so many kids being in recovery and so many kids from different places. And depending on how that recovery is going and the dogma that they're being sort of washed up with, is it concerning? Any thoughts on that?
Yeah. I could see it go both ways. And unfortunately, sometimes it goes in the wrong direction, if you will, because I think that the environment that the recovery community and some of the treatment facilities create is what will really, really dictate the quality of the recovery experience. So as a sober living environment, for example, or a treatment facility, for example, that's dealing with people from all over the country, it's a destination type treatment, a model in California. If they are set with solid structure, if they have individuals that lead the way, that show the way, that know the way, that are non-judgmental, that practice through compassion, that treat everyone like human beings, that create a brotherhood, a sisterhood, that are able to create what a healing environment and space looks like. An individual that's in their 20s comes in here and gets placed in that system, all of a sudden, for the first time in a long time, they might start to experience healthy boundaries, healthy relationships, healthy connections. They might feel safe, structured, supported. They might feel like they're actually making progress in life. However, if the treatment center or the sober living environment is unhealthy, if it's toxic, if it is created for the wrong reasons, and an individual comes and gets placed in that treatment facility, and all of a sudden they're gravitating towards the wrong people, the wrong places, the wrong things, and innocently coming into recovery, it's not actually helping the recovery. It's not helping them progress. It's actually it's detrimental to their forward progress. Then it could be really harmful. So just like everything else in life, I think, Dr. B, that the environment shapes a lot of human behaviors and connections. The treatment center matters. And that's why I wish there was more accountability on who can create treatment and what it looks like on the inside, and what are they actually providing to human beings. And I'm in, as you know, there's no lie about it. I'm in the treatment industry. I'm proud of it. I do believe that we do some good things over there, but it's because it's by design. It doesn't just automatically happen. It takes a lot of internal training. It takes a lot of education. It takes a lot of putting your hands in the weeds and getting dirty and being there, day by day, and just, a lot of blood, sweat, and tears to create a certain environment. Does everyone do that? Not so much, and it's such a waste of opportunity. So I'm also a believer that not everybody needs to leave their hometown to get sober. Long before the treatment industry boom, people got sober and stayed sober in their hometowns. And if you don't want to use that the term sober, people got healthy and stayed healthy in their hometowns. So you don't necessarily have to leave to achieve that. Is it easier sometimes to remove yourself from certain distractions or people, places, and things and all that kind of stuff? Sometimes, but is it always necessary? No. If you have obligations at home, if you have family, if you have commitments and you can't leave them, you can still achieve a certain level of success where you live, no matter where that is. So I have seen that. I mean, the culture of recovery, it's good and bad, just like everything else, there's good and bad. And I'm trying to do what I can to stand on the side of creating positive, role models and connections for people. So when they do get into the recovery communities, they get treated like human beings. The place that I'm at, we're completely non-judgmental. There is someone put a question there, why AA or NA don't like MAT? It's two completely separate things. True treatment should actually be an advocate for medication-assisted treatment. And NA and AA just isn't treatment. It's just a support group that's by paraprofessionals, individuals that are clean and sober. And I'm glad that enough members of AA and NA stood up and said, hey, we have a lot of brothers and sisters that are on medication. We want to treat them better. So that's where the MARA meetings got created. So to this gentleman, I would also say, go check out MARA meetings, MARA, Medication Assisted Recovery Anonymous. And you don't have to be on medication assisted recovery to go there. I know people that go support their brothers and sisters that are on it, and they get to share. There's a lot of compassion. There's a lot of non-judgment, and it'll come through. It's just anything that's new, there's always going to be resistance in the initial stages, So that's what we're feeling right now. Just a little bit of resistance from the way things used to be to the direction it's going right now. And once we get through that, naturally, it'll start to smoothen out a little bit.
Nice. Thank you for that.
Yeah.
Let's see. Tell me if you see something.
Chanel did give you a little bit more information.
Well,
Chanel gave, I'm on 10. Yeah, there's one actually above that too. I'll read that. You don't have to click on it. It says, I'm on 10 milligrams Suboxone a day and 4 milligram lorazepam and 2 Zopiclone at night.
Yeah, it's like Ambien.
Okay.
Where are you reading that?
It was at 302.
Damn, you're pretty good at this. Wow.
So she gave that to us.
Mm-hmm. And I guess she's all of a sudden off of all of it, or just the subs? Yeah. What do you mean, Chanel? You got to come on, my dear, and
It'll be a lot easier.
Because we got Kat here. Chanel, come on, and we'll help you out. Here's one of my favorite persons. I'm going to bring her on, Kat. Hello, my dear.
Hi, how are you guys?
Hi.
Nice to see you and nice to meet you, Parham.
You too, Kat. Thank you for all the side comments. We appreciate you.
Yeah, sure. It's great.
Parham,
I look forward to Sundays.
Yeah, she comes on and she lives up in Northern California, some areas that I really near. I won't say the city, but near Stanford and stuff. And
Yeah.
she's awesome. She's up there. Hi, how are you today? What can we do for you?
Not that far from you guys. So my question, and this has been a question for a long time, it's like our brain is very complicated, but with all the technologies that we have these days, why is it that we can't, doctors can like x-ray and exactly find out where is not functioning and why is not? Because that will help with the stigma, like any other organ that they do x-rays and they can find out what's going on. Why is it? Because it's complicated. Why is it hard to diagnose visually mental diseases? Sorry. That is pretty much my question.
Should I start?
Yeah, well, I mean, I know one thing. So you definitely know more than I do. The only thing I know, we have a local resource here that I've used in the past for certain patients, and it's Dr. Amon's clinics. Is that where you're going to go with, Dr. B? Was that where
I knew you were going to say Amon.
Okay. So Dr. Amon clinics, he has this device called a SPECT device, SPECT, and what it does is it actually looks inside the brain, and it looks at blood flow, and it looks at various things like impulsivity and ADHD, and it looks at, he's even been creative enough that there was an adolescent, for example, that said he doesn't have a problem with smoking weed, And what they did was they took an image of his brain prior to smoking weed, and then they allowed the kid to go in the parking lot with his, and smoke some weed and come back up. And when he came back up, they were able to show differences with parts of the brain that was responsible for memory and all that kind of stuff like that, with actually looking at the brain. So it was a form of intervention, kind of different type of intervention that he used. But so there is that I'm aware of. Now, is there more than that? Probably. Yeah, it's Dr. Amen Clinics. If you look it up, he's in Newport Beach.
Amen. Spect.
Yeah.
Okay, I will look it up. Thank you.
Thanks for that, Parham. Now, I'm going to take your question. First, I thought you were talking about addiction, but first I'll take it with addiction.
Part of it, addiction is, or any mental.
Yeah, mental health. But let me answer that one first. And I'm going to interpret the question to mean, hey, there's stigma. Why don't we just show people it's a disease by showing them, hey, it's a different brain, and therefore it's a disease and so forth. I'm going to interpret your question in that way. And so the answer in terms of addiction is we have massive data in that in that area, huge, especially with sort of scanning with basically what you call active images, PET scan, and nowadays with some of the MRIs, I can show you a lot of this stuff. Where I can also show you a difference in size and brain anatomy and growth of certain frontal cortex, and so. In fact, I can show you certain things like Parham. We talked about this. Awesome. If a kid comes in an environment and there's all kinds of abuse, emotional, psychological, early on, as he goes through his trajectory of growth, his brain size will develop slower compared to the rest of his peers in a statistically significant way, right? That's the extent of data we actually have. We have a lot. So that's for addiction. So it's there. That's why we call it, to a great extent, disease. Now, but see, that's a different thing also saying than diagnosing. So, so I can extensively show now with mental health, let's say schizophrenia. I can take a schizophrenic and show certain changes in the size of certain parts of their ventricles, for example. Okay. But that's not to diagnose it. It hasn't meant to use a tool to diagnose is a very different thing than to use a tool to even validate a diagnosis, to use a tool to make research and theoretical comments or claims about something. So for the most part in psychology and psychiatric disease, we're not there, and I don't believe in doing that for diagnosis of anything anyway. That's a whole different story. But for addiction, we are there. Most of the textbooks, most of the references, most of the way I rest my approach to addiction. For example, my harm reduction approach to addiction. If I get a 25-year-old that has been doing heroin and methamphetamines and everything else since he was 14 and comes from a crappy background, and now he's 25, now I got him clean. Well, if we recognize where he's at as a society, we would understand that he does not have the tools to be an adult at this time. His brain size and the development of certain structures are still operating at when he was 16. So the cheapest way to go about this, the kindest way to go about this, is to create social services for those people to bring them up to par so they can have a quality of life and live well. We don't, so it exacerbates relapses, it exacerbates the stigma, it exacerbates the present industrial complex and how it goes. So it's there, but I don't know. We're not a society driven by formal understanding, but reactions.
Yeah. Okay. Yeah,
That's
because a lot of people think it's all just your emotions, and a lot of times you have control over, addiction or any type of mental illness. And that's just mind blowing, though. Like, why? I mean, brain is an organ and it can be, you know, broken or it breaks or get ill. I just don't understand why people think anything that's like not is not the physical brain, but it's like your emotions and you can snap out of it. It's just, yeah, it's definitely a huge stigma
And
everywhere.
Parham, I do know the Ames Clinic, and I think the spec machine is sort of the same thing as I think he does a lot of sort of progressive kind of work. I don't know how validated the data is. I hear a lot of good things about them from people, and they get a lot of good responses. How about you? Have you heard quite a bit, Parham?
I've heard good things, and I guess they don't fully diagnose it. They just say based on thousands of that we've seen that have the similar results, this is what we could lead to. So they kind of speculate at the end of it. It's not a full diagnosis, but then they have, but it's a nice organization. I mean, I've referred people there, and their feedback was good.
Me too. I mean, people have come from there to me, and
likewise,
they were happy from them.
Yeah.
Yeah.
It's worth looking into.
Yeah. I know I did that, was it TMS? The one that they put like a cap on your head and it just kind of zaps. It didn't help, but I mean, that was the closest I got. That it was very painful for me, and I went to like 10, 15 sessions. Is it called TMS? I think you guys know what I'm talking about, Doctor.
Is it the transcutaneous wave thing?
Right. They tried it so many times. It didn't work at all, but that was interesting too. I don't know.
How are you doing lately? All right?
Yeah, I'm doing good. Yeah.
Good.
How are you? Good? Yeah. I will see you next week. I think we have more.
Okay. All right.
By the way, Happy New Year. Happy Persian New Year.
Thank you. Yeah, thank you. Thank you, Kat.
Yeah, good to see you always. Thank you so much, both of you.
My pleasure. Our pleasure.
Thank you.
Thank you, Kat.
Thank
Bye.
you.
Doctor, there was one at 312. I just like it because it was ice cream from last week that we spoke to, but they wrote that thank you everyone who saw me speak last week and for all your support. My therapist even came on and watched it during the week. So that's the kind of stuff I'm talking about. It was
where is it?
312 today. I remember talking to ice cream last week.
I did too. There's
312. There you go. But the fact that the therapist even came on and watched it, that's the part I like, because that's the type of impact that, because that therapist has a caseload of human beings that he or she works with. And, if they recommend it to their colleagues, and before you know it, not only do we have participants here, but we also have professionals simultaneously in a community together. And that's how you make change happen.
Yeah, that's pretty awesome, right? So, ice cream, thank you so much for sharing, and we're always here for you. Let's see. Tell me if you see something. The comments are too many for my brain to keep track of now. Every time I see Kat, I think of where she lives, and I want to be there because I'm from the same area. And I become envious of her. I keep looking at the weather behind her. Here's another one from Chanel.
Oh, she's struggling. She doesn't feel comfortable coming on because of her symptoms.
Yeah. I mean, you don't have to, we don't even have to see her face. You can, I don't think we do. I don't know. And she's in New Zealand, and I don't know what there's no money to join us as a member, Chanel. There's a Patreon, but it's not it's free. We're here.
There was a Matthew too from 312. He's had about 3 comments, kind of similar to what we talked about with Ollie. Matthew at 312, you can see. There you go. So I was treated so poorly by doctors and nurses when I was in the hospital earlier this year, though not the number one reason for weaning myself off it. It was one of the reasons. Tired of being treated like trash. And he was talking about weaning himself off of Suboxone. It's been about 30 days now. He's not feeling well. And about a few comments underneath it, he just says he's at 316. Yeah, there you go. He's just extremely exhausted, feel like he's walking through quicksand. And it's as if we're talking to Ollie, wasn't it? It was very similar to
Sure is.
The symptomology that he was experiencing. And actually another person too. So this is real stuff, man. People are actually going through this, and it's good. It's educational, and it also shows the negative consequences and impacts of tapering things off yourself, without going through a proper taper.
Yeah, that's a big thing. I always say that this is not something you come off or go up on yourself.
Yeah.
For Matthew, is there more from Matthew?
I don't think so.
I mean, without knowing much about his particular case and advising to follow up with the physician if everything's healthy, really the same stuff we told Ollie applies to you, Matthew, and it's going to get better over time, buddy. And that's my thoughts on that. It's crazy, right?
Yeah, absolutely.
I'm trying to. Let me take a look at TikTok here. Hey, guys, on TikTok, if you got a question, go on the channel. We are still here. We're getting to that kind of a 2-hour mark, but we're here right now, and we'll answer your questions if we can, guys.
There was one at 314. It was a Chris Joe, CRYSJO, 314. And he or she says that I hate how all the pharmacies treat me like trash when I pick up my Subutex up. So, we have that caring pharmacist here that was talking about how a simple interaction, treating people with dignity and respect, help them, feel good. And I hope more pharmacists do that. My question here would be not just to this individual, but in general, because of the negative stigma that sometimes medications like Subutex have in like the recovery communities, how much of that do they wear themselves when they go there and feel like they're doing something wrong themselves? I've seen this with people, that they feel like they have like this sense of shame when they're on a medication, when they, if they've taken it for the right reasons, through the right channels, with the right, consultation under the doctor's supervision, the shame shouldn't be there. Yet there's still a lot of people that connect shame to medication. So maybe it's both, maybe it's none, but that's just what pops up in my mind.
Yeah. So, Chris Joe, thanks for the input. And this brings up a point here. Now, pharmacists, and this goes across all healthcare, again, they've fallen into this where all of us have, without a choice, into this industrial complex where we're not professionals anymore. We're working for the man. And so, the ones that are working for these big chains, they get their things from corporate top, and they always, I think a lot of professionals feel a threat to their license themselves. And, you got to be very confident in what you're doing to not feel that way. So, that happens. But here's some thoughts I have. And, I'm thinking about, making an ebook about this kind of thing. When you get a physician, one of the things I highly, highly recommend, guys, and I don't know if all physicians do this. One of the things we do is, if it's logistically possible, Parham, for my patient to do so, I use one pharmacy. And the pharmacy I use is a small pharmacy. And I always announce to the patients, I like to use this pharmacy. I can actually say it on your Saddleback Medical Arts Pharmacy. Why? I tell them, number one, I have absolutely no financial affiliation with this pharmacy. As far as the reason I use her is because this pharmacist knows me really well, will get to know you really well, treats all the patients. In fact, every patient I've sent there afterwards, even if they move, they end up getting their medication from her and move all their scripts over there, because treats everybody with kindness, respect, gives great service, is very knowledgeable, but most importantly, it protects me as well, and it protects the patient. because now we have a circle of care that's delivering that professional care, understands the nuances of shit happening. Because, you know, if I've taken care of you for 3 years and there's been no evidence of diversion, misuse, or abuse, and you call me, you're like, shit, dog, I left it in the plane or something. I'm not going to say, you know what, dude, I'm going to document this and write what happened exactly, but I'm not going to say, go get me a police report now as you're withdrawing, and there's no pharmacist that's going to fill it without it because you got the script 2 days ago. But you can go to Jesse, and me and Jesse are going to document, you know, patient's been under our care for 3 years. There's never been any evidence of misuse, diversion, or abuse. Clinically, we feel justified in refilling it this one time, and the patient was educated about being more careful with their medication, even though this doesn't happen. And that's, you know, when we're talking about stigma, that is one of the pieces of advice I have. And I want to add to that, within that circle of care, add your therapist, add your counselor. Make sure everybody's on the same page and knows where you're at, whether it's your pharmacist. This is stuff that I've been wondering about. You know, your pharmacist, your medical doctor, your therapist, your counselor. Now you're creating a circle of care that can, A, deliver better care for you, because what's missing in my world now is also communication. 2, if you ever have any ups or downs yourself personally, now you feel more in a cocoon of safety to open up to one of us. 3, if the world is shitting on you and trying to mess with you and say, oh my God, you're in for delivery, you've lost your medication, get pulled over by the cops, you got a team that have your back and everyone's in communication. And this is one of my both prescriptions for both breaking the stigma, but also for mitigating crap that happens during your recovery for stigma. And I've been wanting to say this on this for a long time, but it just came to me. Sorry.
Oh, no apology needed, man. The multidisciplinary team of professionals that are all educated and communicate with each other and actually give a shit is a good model to go with.
Yeah. No, I really advocate for that all the time. Yeah. And it's one way to protect the patient, the client, whatever you want to call yourselves. And it's also good care. Good care should be communication.
Yeah, and you know, I like how you put the therapist and the counselor and stuff in there too, because there's nothing worse than an individual getting the right medication with their doctor, going to the pharmacist and getting a good experience, then going to a therapist or a treatment center saying, hey, if you take this medication, you're not actually doing it the right way. You know what I mean? So it's kind of any part of that loop, when it's broken, it breaks the entire treatment.
Yeah, and also sometimes the therapist has great insights to let you know. The patient hasn't come to you. Maybe the appointment's next week. They just saw the therapist, and they tell the therapist, my husband left me today, or my wife left me, or, whatever it is. Now, if we're on this circle of care, and the therapist can give me a buzz, or my office was, hey, there's a stressful situation with Linda's life right now. Just so you know and I'm like, oh crap, thank you. The appointment's not for another 12 days. We're going to reach out right now. It's just good care,
Absolutely, man.
Anyway, okay, let's move. Ollie, I see you're chatting with Nicole on Real Talk Recovery. It's
yeah, Ollie's doing great. KM at 328 told Ollie, glad you shared and you looked relieved and empowered. Stay strong. So the same observation that we had, KM had of Ollie too. So
where is that?
It was at 312 today, I think. So it's a little bit up.
Oh, 312. I want to put up whatever you point out. I want to put it up just so.
At least I think it was 312. Maybe not. No. Maybe it was down here somewhere.
No, I think you said 328.
Let's see.
Oh, he's up. Okay.
Yeah, 328. Yeah. KM told it's people that we talked to or talked about. So it's just the discussions generating itself. So Ollie, there you go, man. Someone saw you. They were happy you shared. So for everybody that here watches this show, you make an impact when you share to other people. And to see that you feel relieved and empowered, and the fact that you're participating in the chat, man, you created all that. So thank you for participating in this discussion. Without you guys, we would be just two guys sitting in our houses chatting on a Sunday. So we need you.
I feel bad. Guys, I just want to let you know we are getting to that 2-hour point, and we don't usually have a time thing. But today I do have an engagement, and I apologize for that. I do have an engagement today, and I want to kind of get close, if it's okay, Parham, to shutting us down for the day. Yeah. You know, my obligation here today is kind of creeping up on me. But let's see what else. I mean, this is great. I mean, I think guys, Parham, give any feedback, or if you see something you want to answer real quick, let me know. But look, we're kind of gaining momentum on this, and I'm telling you guys on TikTok as well, get on the channel. This is weekly. We try to answer quite a few questions. We're getting questions from people all over the country and all over the world. In fact, we had someone from, was it Bosnia?
Bosnia, yes.
Yeah, we had someone from Bosnia. It's pretty cool. This is going to be a regular thing. Parham and myself, he has his TikTok. What's your TikTok called?
Addiction Therapist.
Addiction Therapist, and a 1-minute therapist on YouTube. But this is something we're going to do regularly. We need everyone's feedback. Parham, I'm thinking on the channel, we can even put on the community tab, we'll talk to Austin about getting feedback or questions. The questions we start off with, like, for example, today, the stigma, right? Ending the stigma. This is not something where him and I are just going to discuss and present over 2 hours. The way it's been working out, and Parham, we can do whatever you want. We use it as kind of a starting platform to generate a discussion, and that's sort of the theme thought. But all questions have been open and coming to us, no?
Absolutely. And let's keep it that way. I like it. That way, the participants, the viewers feel like they have some, they have some skin in the game too, and they can utilize this time to get the support they need, because it might be different than what we're offering that day.
Absolutely. So we're going to keep it that way. So again, I think it's a great platform. Look, you got a couple of professionals here. I know Parham's knowledgeable. I think I'm pretty knowledgeable. We're here in your support. We're here to give you as much information as we can. Always remember, we can't really give detailed clinical recommendations just because of the nature of the engagement and interaction. Every Sunday, 1:45 p.m. We love the community that's growing on here. We're already getting cool-ass feedbacks from people, man. Ollie, I want to see you in the next few weeks. I want to see how you're doing. Yeah, it's important to us. You seem like a great guy. And I feel so shitty when I hear the kinds of things. Parham, give me some feedback. Give people some love so they know we're going to be here and doing this.
No, I mean, absolutely, we're going to be here. And if you missed these or didn't catch them, just go through and watch the interactions. And I can guarantee you that each interaction we have with you in the ongoing weeks is going to be based in like compassion. We're actually going to listen. We will individualize it to the best of our ability that we can. And we really are here for breaking the stigma like today's conversation was, but also educating, empowering, and creating a community that's going to go do some wonderful things. So thank you so much, everyone, for your participation. For those of you who shared and those of you who didn't share, thank you for being here. And our hope is that next week we can continue the same momentum we have with your support.
Yep, I feel the same. And thanks again, Parham. And sorry, I mean, it's about 2 hours, but sorry, I got to get going today. I'm going to go end the broadcast. Nicole, we'll see you soon. I'm going to end the broadcast here, and then let me end my YouTube.